Great. Welcome back, everybody, and Happy New Year. I'm excited to see the group filling up again. I anticipate that a lot of people may be watching this afterwards. I know we've heard of people watching this as teams. So certainly a lot of different ways that you can engage in this material, and happy to just hear that individuals are engaging in this material. So today, as Dawn had mentioned, we are talking about best practice considerations. If you are joining us for the first time, welcome. If you are coming back, welcome back. Wanted to take a moment here on slide number 2 and just review our last webinar where I think it was one of the most important webinars that we did. And I think next month is going to be another one of those really, really important ones. So last month, we looked at procedures for assessment. And I tried to really give you a lot of specific information that you could use, a lot of links, a lot of resources. First of all, related to what are the signs and symptoms of pediatric feeding disorder specific to each of the domains. Remembering again, there's the 4 domains. And looking at each of those and breaking those down, and then giving you a list of available assessment tools, which we looked at all of those together, and reminding ourselves that, again, these are some tools that are out there that are available. They're free to use, and they have been looked at in a measure to say that they are effective and reliable. So there really are some tools out there for us now, which has changed in the last 5 to 10 years and is really exciting. And what I really tried to focus on with those assessment tools and looking at the signs and symptoms of PFD was the idea that, again, you don't have to be a specialist in this, but I'm going to give you the information, the questions to ask, and so that you feel confident in knowing that you are asking the right questions. And then delineating again the team member assessment responsibilities and who is looking at what specifically. So again, I think that was a really important webinar. If you weren't able to join us for that, I highly recommend that you go back and watch that one and recommend it to a friend. So let's move on to slide number 3 here. Again, that reminder that I've been sharing with you, promoting every single webinar here is that school teams are not medical teams, and also that it is not expected that you will become a specialist in pediatric feeding disorders. The number one best practice consideration is to develop enough expertise to ensure student participation and safety. And this means recognizing what is outside of the current skill set of the IEP team, collaborating with medical team members, and possibly contracting out for services when indicated. And I know that last point there might be a sore spot for some of you or for some districts, and I do want to acknowledge and realize that, again, everything we talk about involves money. And so that may be a financial challenge for some districts. I know that any of us who work in pediatric feeding disorders are always happy to at least problem solve and answer a question. That's the beautiful thing about having colleagues and connections. So even reaching out to your friends in the field are going to support you in helping to become more savvy in this area of practice. So when we look at school teams in Wisconsin, I want us to look at, again, the idea of collaboration and implementation versus direct therapeutic intervention. And I love this visual that I found in the idea of collaboration in schools involves teamwork, exchanging of information, support from multiple levels, support from our paraprofessionals, support all the way up to the administration, right? Sharing of information, and then trust. And building that trust can lead us to role release, which is one of our big goals. So let's talk a little bit about direct therapeutic intervention. And what does that look like? So on slide number 5, I want us to talk a little bit here about treating pediatric feeding disorders. Now, for me, this is my glory. This is my joy. This is what I do most of the time. I love treating pediatric feeding disorders. But I remember when I was a young grad and became interested in this area, that it was still something that I would say, nerve-sighted about. I was nervous about it. I was excited about it. And I did recognize, and I want to again recognize for you that this is considered a specialty area of practice. And I think that that is something that our accrediting body, the American Speech and Hearing Association, does do a nice job of, is recognizing that while we have the big nine, right? Remind ourselves going back to grad school, we had language, we have voice, we have fluency, we have feeding and swallowing, we have social aspects of communication, we have speech sound disorders, we have, what am I missing? I'm missing a couple. Augmentative communication, hearing. I'm missing one. I'm just going off of my brain here. But thinking that we have these 9 areas of practice that we all graduate in, and we are expected to be minimally competent. That's how we graduate students. I know, as somebody who works in the universities, we graduate you with the idea that you are minimally competent in all of these big 9 areas. And that is both exciting and terrifying, right? When we think about all the specialty areas that there are. And so one of the things that ASHA has done is to say, okay, we have these special interest groups. And so as speech therapists, we know we can go into these special interest groups and we can learn information. But this is a team approach. We're not just looking at speech language pathologists doing this. We have occupational therapists, we have physical therapists, we have our paraprofessionals, our special ed teachers. We're all part of treating this group of individuals, this group of students. So from the feeding standpoint, as far as the speech therapists and the occupational therapists, again, this is considered a specialty area of practice. It requires extensive coursework. And I know, again, as a instructor, sometimes, I won't say sometimes, every semester I get a student that says, I want to meet with you, Mrs. Eggert. I say, okay, what do you want to talk about? And they say, I want to be a speech therapist that works in the NICU. And I'm like, oh my goodness, like that is such a big long-term goal. That is so exciting. But let's talk about what that involves. And I feel like this is the same arena, right? We really have to look at all of the coursework that we need to get into this area of practice. So thinking about oral motor, how our mouths move, oral sensory, how we take in that information through the taste receptors and the smell receptors and all of the other sensations involved in eating, right? Seeing the food, hearing the food, feeling the food. There are individuals who spend a significant amount of time in the hospitals looking at, performing, analyzing video fluoroscopic swallow studies. We need to be trained in diet and texture modification. And then we move outside of our direct scope of practice into all of those other areas that are also important for us to know about. So then we also need to take coursework and understand the interplay between all of the systems, the gastrointestinal system. I often say, as a speech therapist, I never thought I would spend so much time of my career talking about puking and pooping, and yet I do. It's something that I talk about with every client I meet for the first time. Do they ever throw up? How are they doing with pooping? Pulmonary considerations, cardiac considerations, postural considerations. So again, there are specialists that treat these areas, but we need to understand them. In treating pediatric feeding disorders, I want us also to be very transparent in that research is still growing. It's especially growing in the area of pediatrics. We have a lot more research in the area of adult dysphagia that has been generalized over the years to the pediatric population. And that, of course, isn't always best practice. We know now that infants and children and toddlers are not just little adults. And so there is a whole new and growing and have grown field of research related specific just to the pediatric population. But really that field is very new. It's still young. And so that is something that, you know, we need to be transparent about. I'm going to just look at this thing here in the chat. Oh, somebody was saying that she's a medical feeding SLP for 20 years before the schools, and she teaches grad courses now. And she said that there's always a couple of students who think they want to be peds feeding therapists, especially in the NICU. Yeah. And my response to that is always, do you realize it's not cute babies, it's sick babies, right? So the other thing about treating PFD is that there's many hot topics and new findings. So for example, I'm going to share with you all of the things I've learned and all of the things I've changed. So if you've ever heard about VitalStim or eStim, occupational and physical therapists have been using it on big muscles for many, many years. And in the speech therapy world, we said, wow, we should really get into this too. Why aren't we doing this? And I went and I got VitalStim certified specific to pediatrics. I used it some. I did have some success with it, especially related to school age and older or teenage children or young adults. But all of the recent research that has come out related to VitalStim has stated, at least for the last 5 years, if not more, has stated that VitalStim is not appropriate for pediatrics, especially in our very young population, because it pairs the stimulus of pain with eating. And so guess what? I have a VitalStim machine. It's sitting and collecting dust in a bin in my office. Horns and whistles, all sorts of things about horns and whistles have happened, right? And so, yes, we thought that we used to be able to take horns and whistles and to be able to make lip closure or all these fun things. And again, we know about NSOMs, right? Non-speech oral motor exercises. We know that that is not something that is evidence-based. We've talked about tongue tie too. There are two very, very valid sides to that story, but something that has to be carefully looked at by an entire team. So again, the research is still growing and things are moving a little bit faster now. So whereas we have years and years and years of research on language and speech sound disorders, this is something that we're still learning about. So it's good to remind ourselves of the idea of using evidence-based practice. Now, when I think of evidence-based practice, I think of our little triangle, right? And our triangle always looks at the best, most current available research, your own clinical experiences, and then, of course, the caregiver or patient or client's considerations, and that pulls in all of our diversity pieces too, right? But Dawn, actually, I want to give props to her, found this really, really nice visual here on Feeding Matters. Again, if you haven't been to that website, it is just, you could get lost in there for days. I've spent hours on this website and I've never seen this. So Dawn found something new, which I love. So on this visual, they state, using evidence-based practice is the integration of clinical practitioner expertise, external evidence, internal evidence, and client, caregiver, and family unique perspective, values, and cultural beliefs, which I just explained. But what they do is they then break it down and say, number one, remind yourself to assess and discover the client's needs. Ask a complete question that targets what the client or professional is in search of answering. And you all know you have to ask those questions again and again and again, and in multiple ways, right? Acquire, conduct a literature search to determine what the current research is saying. Appraise, determine if the evidence is credible, valid, and if it applies to the clinical question. And apply, use the evidence along with your clinical judgment and values of the client, then evaluate both your overall performance and the client satisfaction with the evidence-based practice process. So one of the things that I think, again, this shows us as a reminder of, go back to the research. Feeding and swallowing disorders in general, especially in pediatrics, has research now, and that's very exciting. I think a lot of us have been really going back to the research in the last couple of months. I'm wondering, can you just give me a thumbs up in the chat if you are a speech therapist and you saw the article that looked at just Gestalt language processing and natural language acquisition. If you saw that big research review that came out. I know that for a lot of us, that was like, yeah, a mind-blowing moment, right? And so we just had a discussion about it yesterday in a team I worked on, and we all said, gosh, we feel confused. And then we all said, you know what, we should have been looking in the research more. Yep. So thank you, Jen. Thank you, Lisa. Thank you. Yeah, Amelia, Anna, Caroline. So I'm excited to see what comes out of that. But again, it's just a beautiful example of something that recently happened that we can affirm that idea of using evidence-based practice with. For those of you who aren't speech therapists, for those of you who, again, I don't want to talk about something on a webinar and everybody goes, well, what is she talking about? There is a very, very well-known practice model of looking at how children look at how we look at children with autism and their language processing. And the American Speech and Hearing Association recently published a paper related to that. It was really very interesting to see that, again, we needed to go back to all the things we've known from many years ago. So, all right, pediatric feeding disorders is what we're talking about, though. So that was just an example. So, pediatric feeding disorders in the schools. We came up with this nice little visual here, a flow chart. We are going to take you through the process of the referral, case history and obtaining medical records, interdisciplinary interview and assessment, the IEP, development of a safe eating plan and health emergency plan. And I'm really excited that Louise, our nurse, is here today. And so she's going to get to jump in here for a second and chat with us. Training of staff, consulting and monitoring, and then what is the process for the revision of the IEP and safe eating plan when indicated. So let's jump right into the idea of the referral. So in terms of the referral, we've mentioned this before. Anyone can refer a child. And when that child is referred, they need to indicate the concerns and why they believe the student is a, quote, child with a disability. Now, who receives the referral will depend on your school district. Usually it's the special education director. But each local education agency, or LEA, establishes procedures for accepting and processing referrals. You all know this. You could probably do this in your sleep. The review of existing information and data is where we need to start, right? And I think this is true for any client we see, any situation we see. What do we know? What do we need to know? Specifically, in this case, we're looking at what does the IEP team know about this child? And what does the IEP team need to know about this student, specifically related to PFD? And then, of course, we need to obtain consent for additional assessments. I want to note that I recognize that this could be for a reevaluation or an initial evaluation. We have students that come in and things change, or we learn more information, we learn new information. And so sometimes it is a reevaluation process. Oftentimes, though, it is also an initial evaluation. Okay. So in terms of the case history and medical records, I did give you some information last time, again, with some screeners and some different case history forms. Reviewing existing information and data is going to be very important. Of course, we want to, right off the bat, obtain parental consent to exchange information with outside agencies. This is when we use our administration as a resource. I'm just curious, for some of you, again, can you just put a thumbs up in the chat? Is this the first time that you've ever thought to yourself, I have to reach out to somebody outside of my district? I've never gotten a consent or what we call an ROI, a release of information, to talk to a medical professional. Maybe you've talked to others, to other therapists, to other providers, but I'm just curious if there's anybody that's like, wow, I never even thought about this, of having to talk to a medical team member. And I'm not seeing any thumbs, so that's actually really reassuring. Like, you all are doing this already, which I guess I'm not surprised, because you're all skilled professionals. So that's really fantastic. And if you are going, oh, I don't want to put my thumb up, that's okay. That's okay, right? Okay. So interdisciplinary interview and assessment. Reminders, this is a team approach. So I want to remind you of all those assessment tools that we looked at from last month. And Dawn, when we were talking about this month's webinar, she brought up this really good point that I want to sort of drive home, which is it is okay to use it, even if it's a screener. And I think sometimes we get caught up in the idea of screening versus evaluating, because in our heads, we've learned that a screening is a pass fail, right? And so, or a pass refer. And so we get caught up in that and going, but no, we need an assessment. But these screeners are tools that we can use to help identify areas of concern with individuals or students with PFD. So the screeners in this case certainly may be used as an example of a time when we do need to refer. But my guess is that most of these students may be involved in some other medical professionals. And so it's not that we're referring, we're just using this as information gathering. An interdisciplinary interview and assessment also includes watching the caregiver feeding the student. We talked about that in the last webinar, that it is so important because all of us as professionals, whether you are, again, a special ed teacher or paraprofessional, a therapist, you are instinctive in working with these students. You know what to do, where to put that spoon, how to elevate that child, because you're like, wow, well, this looks like this would make sense. This looks safe. This is what I've done in the past. But what the caregiver does may be different, maybe better, maybe bringing us more concerns. We don't know. And so watching the caregiver feeding the student is really, really important. And then we do want to refer for instrumental evaluation when indicated. Now, what does that look like? Oftentimes that goes specifically to the primary medical doctor, but there certainly could be times when GI is involved and you are asking another medical professional to send in that referral for that instrumental evaluation or that video fluoroscopic swallow study. So in the chat, let's just take a moment here. When would you or have you referred for a swallow study? Because I think this is a big topic is when do you refer for a swallow study? And have you ever referred for a swallow study? Because we have to remember, and I'm going to talk here for a moment while people are hopefully putting things in the chat, is that a video fluoroscopic swallow study does involve radiation. And so if we are going to refer somebody for this, we are absolutely wanting to make sure that this is a procedure that needs to be done because, again, it does involve radiation. So I'm not seeing anybody put anything in the chat, and that's okay. I would think that, oh, here we go. As an OT, I have asked if a child in the past had had one, and administration has not supported my concerns. Okay. I have, but it was years ago. Okay. So if we refer, doesn't the district have to pay for that? Yeah, Dawn, I'm going to let you hop in on that one.
Sure. Well, oftentimes in cases similar to this, if what I will do is I will talk to the parents about, have you ever had this done? This might be something that you want to talk to your doctor about. So I think when you use words like that, it's not you saying, as a school, I'm referring. I will say to the parents, you might want to talk to your doctor about either repeating a study or getting a study done. If a school finds out that they really do need this information and the parent is not willing to, there are times when that cost then would be on the school district, but sometimes that is what the school needs in order to ensure the safety of the child. But in general, if the student has insurance, it would go to that. Then the school would pay whatever doesn't get covered. But I would start with, you may want to talk to your doctor about getting a referral for this or about seeing this kind of person.
And Dawn, does the school still infer liability if you talk to the family and say, I'm recommending that you follow up on this and I'm going to call your doctor about it to help you, to facilitate this, to give them more information?
The school can definitely, and Louise could speak to this too. Oftentimes we had our school nurse make that connection with families when we were, wanting that student to see a specialist, like say an ENT or, other things like that. So Louise, if you want to jump in on how that works for you as a nurse or what you've seen and done.
Yeah, for sure. A school nurse or, a school employee, more beneficial to have somebody with a healthcare degree than the teacher to be suggesting to parents that they have medical evaluations or be evaluated for medication or whatever. Comes better if the person having that has some healthcare credentials. But yeah, certainly school staff, school nurses often have release of informations already with the medical providers, but can indicate and kind of help facilitate that conversation and say, this is what we're seeing in school and this is why we're concerned. I think, again, there's that little bit of a dance, as Dawn alluded to, about who then would have to pay for it. And it's more of a, a school district can suggest that information would be helpful. But if it, basically really firmly that we need to know this information before we can write the IEP goals for the student, or, determine if they even qualify for, special education services, then the school district would have to pay for that. But I think, yeah, any of the, healthcare professionals that are, part of the feeding team could do that. And school nurses often do that, because oftentimes we have releases of information already. And the point being there is, when you do get a release of information, don't put your name on it, put the school districts, because then anybody in the school district can use that release of information, versus saying, like, you have given permission to the Madison Metropolitan School District to talk with, versus Louise Wilson or something like that, or something.
That's a great point, Louise. And I know working clinically, as I still do, I often get those sort of blanketing releases with districts down here, that it's, you may really speak to anybody in the district who is in contact with that child. So thank you for that clarification. A couple points from the chat here is Anne stated, when a child has a lot of respiratory infections, or if they struggle with swallowing. Yeah, anything that's showing that they're a concern for choking or gagging, or choking or aspirating, and that that food may be going into their lungs. And asking for the records of previous swallow studies. Maria asked us here, how often should a swallow study be performed? I have a student that is 4 years old that a parent wants to introduce solids at school. And when I asked about a current swallow study, and parents stated it was 2 years ago. So that's a great question, Maria. First of all, how often should swallow studies be performed? Really depends on the child. Really depends upon what was going on with that child when the first swallow study was performed, and if aspiration was occurring, what sorts of skills were looked at in that swallow study. We talked about in one of the earlier webinars about growth, and how that has a negative impact on our swallow function as we gain length. And that could be true also for some of our kids who are going from toddler years to more school age years. So that is something absolutely to consider. There isn't necessarily a guideline as far as how often swallow studies should be performed, except that they should be performed as little as possible, because again, of that risk of radiation exposure. And we know that that is something that we can also look at as far as swallowing. We can look at with our own eyes and our ears, and use some of our clinical skills. So, in terms of what are they doing with the swallowing, is a pretty complicated question. Okay, so that was great. Thank you for putting that in the chat, because I think that that's always a big point, is people think, well, we have to have a swallow study, and we don't always have to have a swallow study. I can actually say, as somebody who works in PFD, that I don't refer for swallow studies a lot, unless it's really clinically indicated. So all right, let's go on to the next slide here. Dawn's already moved us along. Thank you, Dawn. In terms of interview and assessment questions here, we have an example of a caregiver interview form. We did take these directly from a just wonderful resource, which is one of the individuals who we have learned from the Arkansas-based school district. And so this is some of their work. We want to give them credit. But in terms of this interview form, it's really nice. We have the link there. You can look at it directly. It gives a lot of information related to all of the important factors of who is this, and then some places to describe concerns about the child's feeding and medical information. It right there in the form will give you the link to, is there a GI doctor, a neurologist, a pulmonologist, another doctor? It sort of clues you in. Who on that medical team should you be asking about? Things that maybe the nurse wants to know, such as their current height and weight, if they have any food allergies or environmental allergies. If you look and you click on this, you can kind of see it on the screenshot that we have there. There's that bowel habit question that I love. Sleep patterns, medications that they're taking. Moving on to the next page, they have cues for you to remember about swallow studies, upper GIs or barium studies. Have they ever had a gastric emptying study? They talk about gastroesophageal reflux disease, any esophageal conditions that they may have. There's a lot of them out there. One of the big ones that you may hear about nowadays is what's called EOE, or eosinophilic esophagitis, which is a gastrointestinal disorder that does require medical attention. They talk about asking for frequent respiratory infections or pneumonia, any concerns with nutrition. Do they have a feeding tube? Do they visit a dentist? You know, that dental care is so important, especially for our kids. And Luis, I'm sure you'll agree, our kids who have seizure disorders, because those seizure meds can really be damaging to lung tissue or to gum tissue. And so we want to be really sure that those kids are getting good dental care, because if you get infections in your mouth and you're aspirating, you can be getting even worse infections in your lung. And then they go on to some questions about current feeding practices and food preferences and all of those real specific questions. So again, this is a great resource for you so that you have the exact questions and you know, what am I asking? So we have it right there for you so you don't have to try and reinvent the wheel. Then the next one that we have, again from the Arkansas school district or the state of Arkansas, is the observation form example. And again, we have stated multiple times, it's so important for us to observe what we see. Our eyes tell us so much. And on this form, you can see some observed behaviors that they give you. And you'll notice that a lot of these observed behaviors mirror exactly the screening tool questions that we gave you last time. And so again, these are all of those red flags, those concerns that we're looking for, any additional aversive behaviors, and then anything else that you just noticed. I think, again, I love hearing from everybody. I love hearing from anybody. What have you noticed with this child? Sometimes it's the littlest piece of information that can lead to the biggest discoveries. And so everything should be noted. There is no wrong information. It's just information. And we have to determine if that information is useful to us or not. As you're beginning and working with these children, you may not know if that's a useful piece of information or not. So write it down, because if it is useful, you're going to work with your team to determine that. If it's not useful, that's okay. That's just extra information that you got. So okay, determining eligibility, developing the IEP, and determining placement. I'm going to hand it over to Dawn because she is the expert in this area, and I want to make sure that this gets covered with an expert's eyes. So go ahead, Dawn.
Thank you, Jennifer. Also, Shelley had asked, how do I get copies of these? So the forms, the sample forms are linked in the handout. And just a reminder that at the end of the series, so this series of webinars lasts 9 months, and then we have the summer. We're hoping by next fall we'll have our own guidebook for the state of Wisconsin, and then you'll have access to all these forms and more in that guidebook. But for now, you have examples of the ones that were implemented in the state of Arkansas through their work with Emily Homer. So determining eligibility, developing IEPs, determining placement. First of all, PFD is not a disability category in and of itself. Feeding and swallowing may be a disability-related need under any of the recognized disability categories that we currently have. So often I get asked, well, are we going to add a category for PFD? No, there's not going to be one added, at least at this time or anytime soon. But you look at disability-related needs, and that could be included under really any of the disability categories. So once that is done and a student meets criteria for special education in at least one disability category and pediatric feeding disorder is an area of need, then the IEP team determines what goals and services are necessary to really allow that student to access, engage, and make progress in age or grade level general education curriculum and also in their environment. So some of the things you might look at when you get to those services, you would start with those supplementary aids and services. what modifications and accommodations can be made in the general education program that will allow the student to access the curriculum, meet their standards, and that really applies as all students then, are there changes in diet? Are there positioning needs? Are there feeding strategies? Things like that that might be added in your supplementary aids and services. You're going to look at what specially designed instruction and related services might be needed to meet goals related to their need in feeding and swallowing. So what services are needed to teach and train the student? And then also program modifications and supports for school personnel. What teaching and training is needed for school personnel to provide those students or services to the student. So those are some of the considerations that will be put into the development of the IEP after you've determined eligibility and you're looking at placement.
Okay, I was just writing back to somebody in the chat. There we go. Thanks everybody for your group work. So then we move on to the development of the Safe Eating and Emergency Health Plan. I'm going to talk about the example of the Safe Eating Plan, and then I'm going to turn it over to Louise, who can talk about the Emergency Health Plan, because they are two distinct pieces. So in terms of the Safe Eating Plan, this is going to be where we look at our feeding recommendations. So specifically looking at the seating and positioning. What types of utensils are being done? Is there any tube feeding that's being done during it or after it? That would be separate, as far as the nursing orders for the tube feedings, but also so that we know, because a lot of kids are working on, especially if you're working on tube feed weaning, you may be doing a tube feeding at the same time that you're eating, so that you are starting to pair that idea of hunger with satiation coming from the tube feeding. Diet and food preparation, according to their food consistencies that they need. Is that liquid? Is that soft and bite-sized? Is that pureed? Is that something that they need in terms of their liquid consistency? Do they need a nectar thick or a honey thick? And then any sensory modifications that they need. I love on this feeding plan here, you'll be able to see it when you open it up, that they talk about the amount of food per bite, or we talk about that as, remember we talked about bolus size at the beginning and how big that ball of food is? Bolus size, it's very important that you know that, because some individuals, you're going to think, okay, well, these are children who have difficulty with feeding and swallowing. They're going to need a smaller bolus size. But actually, the exact opposite may be true very often, especially when you're looking at our kids who have any sort of sensory motor components. Some kids actually need a little bit bigger of a bolus in their mouth to be able to feel it, to be able to more successfully move it. And so we never want to assume that. We want to know, where is their area of success? And some kids need presentation to certain sides. Again, do we need to offer drinks between bites or after bites? Do we need to put them in any sort of a upright position or a certain position during or after? So those are some of the things that you may see on a safe eating plan. Again, there's an example here for you from the state of Arkansas, and as Dawn had mentioned, from the work of Emily Homer, again, giving credit where credit is due. I'm going to turn it over to Louise so that she can talk about what the emergency health plan looks like, which is something that's different.
Right. I think you have an example on the next slide, do you not?
We don't, but we could.
You don't. Okay, that's fine. That's
we
fine.
Have it linked
so
in.
when you click, when you do, yeah. So when you click on a link, what you will have is an example of an emergency health plan, or really what school nurses and what we refer to that as the emergency action plan. So some of you that are working in school districts, that's what your school nurse will be talking about and refer to it as an emergency action plan versus necessarily emergency health plan. But generally those are written they're written for school staff to follow, not necessarily for the school nurse to follow. And it's often written in, and you'll see the example that we link there, in a kind of see this, do this format. So if you see them and from a school health standpoint and from a emergency action standpoint, probably the situation that you're going to be seeing one is choking. So if you see them, and again, any person in school could choke but you would do it for, you would write such an emergency action plan for someone who is, they've choked in the past. It's anticipated that they might choke. And so we're going to have the emergency action plan so we know how staff can respond to it. So it would be, you see this, do that. And sometimes it might, there might be different things. So maybe you do have to do abdominal thrusts and that. Sometimes you might have to modify that because the student is in a wheelchair. Sometimes it's, no, you don't have to go to those extremes. What you need to do is say something, and this is the emergency action plan. They're choking, but have them cough, and this is the term that you would use, or this is what you would tell the student, because some students might communicate that differently to them. So again, choking would be the one that would probably be most often used. But again, you would see an emergency action plan for students have seizures, so that would kind of complicate their feeding plan and that. So again, those are the emergency action plans that you would have for students. And I would just mention, when Dawn had said the support services that are supplied for school personnel. In that is where you would also then document in the IEP, you would document that the student does have an emergency action plan. And let's say that it has an emergency action plan, the school nurse is going to train staff on how to, implement the emergency action plan. So the school nurse will train staff on how to respond to the seizures, or they'll train staff on how to respond to the choking incident. So just so you know that, yeah.
Okay,
Yeah, and so
great.
somebody put down, in case again, from a feeding standpoint, if the G-tube comes dislodged or something like that, yeah.
Sure. Jen, could you address, so many of us are not specialists and aren't sure on the consistency and the some of the different modifications. Those would come though from your communications, hopefully with a medical team, if you are to that point. So some of the recommendations on the safe eating plan can be made from the team assessment, but also communicating with the team and interpreting the video swallow results and things like that, right?
Right. And I think, Dawn, thank you for bringing that up, because that's such a good reminder too, that a review of records is part of our assessment plan, right? And so reviewing all of those medical records is part of what we talked about in the assessment. And so if there is specific information and dietary modifications that are noted as a result of a swallow study or any sort of medical professional, then absolutely that information comes from there. And then we can take that. That's not something that we expect school personnel to come up with. If you are working with a student where you have concerns that they do need diet modification, that sounds like or texture modification. That to me is sort of a red flag of there is some significant feeding pieces to this child, and this is going to take a team approach. There should be other medical professionals involved. So, yeah. Okay. So we wanted to take a little bit of time here to talk about neuro-affirming practice considerations. And Dawn wanted me to share this point to make sure that we're not causing long-term trauma for short-term gains. So in the world of working with individuals with autism or autistic individuals, see, now I go back to old school where I put person first, disability second, and now we've learned so much from all of these amazing voices that have come to share with us, is that we used to sort of do this, come here, sit down, do this approach. And we really have learned from a number of individuals whose voices have shared with us that there are pieces to what we were doing that weren't necessarily safe for them in terms of body autonomy. And that is really important for us to take into consideration. So while we do want to try and support individuals in making dietary modifications or gains that can help them to eat a nutritionally balanced meal or diet, we also need to, again, look at what is the big picture here. So things that are useful, of course, establishing routines, right? Creating a calm and distraction-free environment. This is true for me on most days. Allowing meal accommodations. That may mean that a child needs to get up and maybe they need to do 3 circles around their table and then they sit down and take another bite. Maybe that's their routine. Maybe that's their accommodation. Maybe their accommodation is, and I'm saying that because I know a friend who does that. I thinking about meal modifications might be that everything on their plate is only the foods that they are comfortable with and with that bring them that safety in their eating. So that might mean that the tray that is being produced in the lunch line is specifically put aside for them, because if you even put another food on there for them, it can completely throw them off and then they get no food in that day. Remembering that fed is best. And this is something that's been out there, that this idea of fed is best for a long time, not only in our neuro affirming practice, but just in general. The idea that any sort of supplementation we need to do, any sorts of changes we need to do, the idea is that we want the individuals fed, and that's what's most important, right? And experimenting with variety can be done, but again, mealtime is mealtime. Therapy time is therapy time. And we sometimes do what we call therapy meals, where it's really like a little snack where we're experimenting with variety, and that is great. But meals are meals. We have to get nutrition in. Amelia Road, in the previous district, we worked with the kitchen to have one of the ARFID kids have access to the preferred foods on rotation so he wouldn't jag. Food jagging, meaning you get stuck on a food during the week, even if it wasn't on the menu, so that they would eat. Yeah, that is fabulous, Amelia. There's our win for the day. I love that. Looking at difference versus disorders again, right? Like there's the idea of being like a selective feeder as a toddler versus looking at somebody who truly has like ARFID. I don't like broccoli and I don't like cauliflower. But I've been a functioning adult in my feeding world. I can work around that. I'm not missing the entire category of vegetables. Although I do much prefer the category of chocolate. I love this triangle here, this pyramid that's from somebody here in our own state out of the Madison area, Ellen, and I believe it's pronounced Satter. If you want to look her up, we have you can look it up. We have the link at the end there in the resources. It's ELLYN. SATTR. And the idea of this resource is that we have a hierarchy of food needs, right? So, and this is really true for some of our kids and some of our students. And we saw this during COVID, right? Where all of a sudden everybody was at home. And so what do we do? Because there are individuals in the world, and it's growing, that period don't have enough food. And so they come to school, and everybody thinks, so this is like this perfect time of year, right? Are we going to get a snow day? Are we going to get a snow day? Are we going to get a snow day? And everybody thinks, just close the school. It's going to be fun. We're going to have a snow day. But one of the main considerations that those districts have in terms of not only thinking about student safety of being on the roads is student safety. And I know this from working with like Milwaukee Public Schools down here, is student safety in terms of how many students do we have that access food from us? It's a huge consideration for districts. So do we have enough food? Do we have acceptable food? Do you have food that you enjoy? Like getting food is one thing, but then letting yourself get something that you enjoy and is acceptable, like that's really good. Have you ever gone to a restaurant and you're like, I don't want anything on this menu, but I guess this will do. That is me. That is me. Absolutely 100%. Reliable ongoing access to food. That is something where, again, now you're starting to feel comfortable with food, and you can get rid of some of that food insecurity that we see in our students. Good tasting food. So this is like the next level on the hierarchy, right? Like, is it food? And is it food that I can get? And is it food that tastes good to me? So is it I can treat myself because it's New Year's Eve and I'm getting steak and lobster tails tonight, or whatever your New Year's Eve food is. Actually, my New Year's Eve food is takeout Chinese food. But is it really good tasting food that I want? Is it novel food? Am I getting tired of eating takeout Chinese food every year for New Year's? And do I want to try something different? Do I have the resources to do that? And then is it instrumental food? And instrumental food is like, it's sort of this idea of a both and, not an either or. So you eat food you enjoy and you consider it to be good for you. And this is like, if you think about Maslow's hierarchy of needs, like this is sort of that attainment of I have food, I have access to food, I'm enjoying the food, I know it's healthy for me, I'm going to make some of those choices to pick those healthier foods. So this is a great practice consideration to look at, and thinking about, again, not only where are our children on the spectrum in terms of this, but where are all of our students in terms of this? Okay, next slide. All right, next month we'll be back with the training of personnel, as Dawn said, February 5th. We're dedicating the entire topic to this. I really, really hope that we have a large turnout for this one again, because I think this is going to be one of those big ones that we really hit some really important topics, or really, really important points on, is how do we start to implement this? How do we train school personnel? So stay tuned, coming soon. There's your little teaser. And then if we look at consultation and monitoring in that flow chart of what does this look like in terms of best practice consideration, we need to do consultations as per the IEP, and really monitoring IEP goals and the safety of the child. Are the services effective? That initial teaching and training has to occur, checking in with school personnel, monitoring student performance. So making sure, again, that we are doing this ethically and with efficacy, making sure that everybody feels like this is the best. We don't want anybody, not only in terms of the student, but in terms of the caregivers, our staff, feeling like, wait, there are concerns that I still have. We want to make sure that everybody is feeling like their needs are being met. All right. And then the final thing that we may have occur is a revision of the IEP and safe eating plan when indicated. So what might indicate this? Well, certainly any updates from school personnel, caregivers, medical team, or outpatient team. Like, think about our neuroaffirming practices. Think about the exciting moment when that student with autism, or that autistic individual who's needed to eat in a separate space, is now moved from that separate space to eating in the hallway, outside of the cafeteria, so that they can get used to the sound, and is now on that, like, they're in the cafeteria. They're there. Like, that would be a really exciting update. Do we need to update the IEP for that? I don't think necessarily. I don't know. But those sorts of things are minor, but there can be big things too that occur, right? So say that maybe a child has a new medical diagnosis and there are some changes that need to be made. If there are any new interventions or updates to the safe eating plan that are needed, those would be those big things that really, really impact what you're doing. And it's great when we see progress, but when we see anything that's going to impact safety, that's probably when we're going to need to go in and review or revise that IEP. Dawn, do you have anything to add to that?
No, I think you hit on the major points there. You know, yes, really, when there's anything safety wise that's going to be changed, maybe they have had an updated video swallow study and they can have an upgraded diet, you know, so things are going to change that way. Or maybe the diet needs to be changed in the other direction, where, you know, they need to have things minced or pureed, or, you know, just different textures. When you mentioned maybe switching environments in which they're eating, so if their placement is changing from special education, in a special education environment, back to the general education environment, then that would be a review revise type of plan.
Yeah. Good. Okay. So this is when we get to turn off the recording and get into chatting and ask, are there any comments, questions, anything that we want to chat about here